Guys on Zoom, hopefully, if you have a question, just unmute yourself and pipe up. Obviously, I won't be able to see, but Tashina, maybe you can take care of that.
I will.
And good morning to you guys. So, Wisdom Wednesday is what we're doing,
Yes.
which is very cool. I think I've done 3 or 4 of these with you guys before. And the one that I was asked to do today is on families of patients in the ICU. So presumably it's about when families disagree with the care team or with the patient or something like that. But can I ask, does anyone have a specific example that would be helpful to frame our discussion around? They're all pretty generic.
I think one of them is when the families don't agree, like the family members don't agree.
Mhm.
Be something I
With each other or
with
with the
each
patient?
other.
Okay.
You
And
know,
the patient can make decisions for
Yeah.
themselves. Yeah.
that would be the one I would.
Yeah.
I think I've seen.
Okay. So let me give you an example, and we'll just talk about it a little bit. But I have a couple of formal things that I want to talk about. I'll use the board for that. But we had a guy who was involved in a drunk driving accident. So he shows up in the hospital, and he's drunk, of course, but he's able to talk to us. He says, "I promised my wife I would stop drinking. I'm in a drunk driving accident, so I don't want anyone to tell her I'm here." And he was drunk, so they're gauging it. But when the guy woke up in the morning, he said the same thing. "I do not want my wife to know I'm here." So does the guy have the right to confidentiality? Does that include notifying the family that he's here? He's got the right to tell us whether he wants her to know or not.
Yeah. Absolutely.
Does it make him a particularly good husband?
Mm.
Right? Because part of our team was saying, well, she's going to worry, she's going to do all these things. And we said, yeah, she's probably going to do that. But at the end of the day, he gets to decide what happens with his confidential medical information. But people were really, their instincts really were they wanted to notify next of kin. So then the guy deteriorates, he loses the ability to communicate with us, and we're transferring him from one of the smaller hospitals to one of the bigger ones in Horizon. So he gets to the one in Horizon, and they say, oh, you need to notify his family. So in that circumstance, would we have to notify the family? I'm
See,
sorry?
that's the tough one because
Yeah.
he's deteriorated at this point.
I feel a yes, because it's gonna be their last chance to get to see him. But his wishes initially were no.
Mhm.
Those
Yeah.
conditions change.
Yeah, who knows when he says if his condition was poor, he would have gone to the.
But he was pretty adamant. He said, under no circumstances do I want you to notify my wife that I'm here. So that kind of applies even if the facts change, right?
Because I mean, he was cognitively with it when he made that decision.
He was, yeah. Yeah. So the challenge I gave to the team when we were doing this consult was I said, okay, what do you want the wife to do? If we notify her, what is it you want her to do? Any thoughts? What do you want her to do?
Well, she might have to make some decisions, which she's next
On
to
his
kin.
behalf.
Yeah.
So I use this as an example of saying, asking ourselves a tough question. What do we want families to do when patients can't make decisions for themselves? And that's kind of what I want to go through today. So the first thing I want to do is talk about the difference between rights and responsibilities. So if say I don't like pain medication, and say I have to get a small dental procedure or something. Do I have the right to say, I don't want pain medication, but I still want the procedure? I can make like the most absurd decision for myself if I want to, right? I could say, if I'm mentally competent and legally capable, if there's a life-saving procedure that I need, I could say, you know what, I'd rather die than have that procedure, which means I might very well die. Because I have the right to make decisions about what happens to my body. So now, if I lose the ability to communicate or lose consciousness or whatever it is, does that mean I lose any of my rights? It doesn't, right?
No.
I still retain all the rights. So this poses an interesting question. If I don't lose any of my rights, how does a family gain rights? How does a substitute decision maker gain rights? They don't. What they do is they inherit a responsibility. So the relationship between the patient, the family, and the patient changes to one of a new responsibility. So if I have a power of attorney right now, and I'm competent and capable, that power of attorney and I are in one relationship, right? But if I lose the ability to communicate with you, that power of attorney now has new responsibilities towards me, right? So part of it will be, what are those responsibilities? So the first part I want to say is, patients and families approach us, and we approach them when we have conversations with them about them having the right to make the decision as if they have rights. But when we look at it, it's not really that they have taken on my rights. I have the rights to make crazy decisions for myself, but other people don't necessarily have a right to make crazy decisions for me. So the part of it would be, okay, well, what are the responsibilities? Is that okay so far? The difference between rights and responsibilities? Is there anyone disagreeing with me? Would anyone say, no, actually, families have rights? It's kind of a subtle distinction between the term right and responsibility, but it's an important distinction. So then if we say, what are the family's responsibilities then? But let's talk about it. So say someone shows up in the hospital and they're in emergency, they're transferred to the ICU. Do we have a clue who this person is? We might not, right?
No.
Might be the very first time any of us have seen them. So that makes the family member or the substitute decision maker or the power of attorney or whoever's with them very helpful, because they can tell us something about the patient. So they can say, you know what, this is my wife or my husband or my partner, and we've had a conversation about life-sustaining treatment before, and you know, if there's no hope of them ever getting out of the hospital, they might not want to start. So they would know that because they know the person, we don't. So that means the first responsibility, I'm going to set it here. The first responsibility of the substitute decision maker is to help us figure out what patient's previously expressed wishes are. Does that make sense? So if there's any power of attorney, if there's any advance directive, if there's anything that can help us make a decision, the first thing we're going to do is not say, here's what we as a healthcare team want for the patient. First thing we're going to say is, wow, if the patient could tell us what they want, that would be very helpful. And now you're here as a substitute decision maker, you're in the position to tell us what they want. Now, there's got to be some rules about this, right? So with a family member, is it possible for them to lie? Is it possible for them to talk about what they want more than? So I remember there was one case we had where this guy had a stroke, his wife died after having a stroke, and he was a lawyer. So what he did was, after his wife died, he sat down and wrote up an advance directive. And this is before advance directives were legal in New Brunswick, but he wrote it up. And he was a lawyer, so he had it notarized. And I said, if I have a stroke, I do not want any help with nutrition and hydration. I don't want any help breathing. I don't want any help fighting an infection, blah, 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 blah. Basically, sit me by the window and let me go. So then a few years later, the guy's got a new girlfriend and he has a stroke. So he comes into the hospital and we're able to communicate with him. And we said, look, you need help breathing right now. So we're going to do invasive mechanical ventilation. But we think if we do it for a short period of time, you'll actually live to be discharged from the hospital. And he said, oh, no problem. But he had this advance directive, right?
I don't know what I was talking for. I got distracted by that. I think it's an extension to that. Someone else.
So the guy had this advance directive, but does he have the right to change his mind? Yeah, absolutely does. So now, fast forward a couple more years, he has a massive stroke, and he loses the ability to communicate with us, and he also loses the ability to eat and drink orally. So the discussion is about whether we're going to put a feeding tube in his stomach. So his sons come in, his two daughters, the youngest two girls, bring out the advance directive and said, our dad would never want a feeding tube after having a stroke. It says it right here in black and white. The two oldest sons said, look, our dad's a different guy now. When he wrote that advance directive, it was an emotional reaction to the trauma of our mom dying Now he's got a new relationship. It's 10 years later. He's a different person than when he wrote that document. And the middle son was in a wheelchair, and he said, when I was born, people didn't think my life was worth living either. So you can see here, all of the kids are trying to say what the dad's previous wishes were, but they're all giving us their own value, frankly. So one of the rules about previous wishes is that it has to, the previous wishes have to apply clearly and unambiguously to the fact situation. So if we have a person in the hospital here who says, I never want to go to a nursing home, I would never want to go to a nursing home. No problem, you don't have to go to a nursing home. But then something changes and they're no longer able to make decisions for themselves and they're no longer able to live in the community on their own. When the son or daughter says, my mom or dad said I never want to go to a nursing home, we would say, well, that was when the choice was between hospital and home. Now the choice is between hospital and nursing home. So that other option has changed. So those previously expressed wishes can't apply clearly and unambiguously. Do you see what I mean? So that's the first thing we want our family to do. If we don't have that, then the second thing we want them to do is tell us, well, what's the patient's values and preferences? So we had a patient in one of our transitional care units, and she had advanced dementia, and she took a liking to another person, one of the guys, and it was getting somewhat sexual. And her nieces and nephews said, well, our aunt was a Roman Catholic sister. She was a nun. So even though she wants to do this now, if she could talk to us for a minute, she'd say this is an indignity to her. Maybe it is, maybe it isn't. Other people, other patients would say, you know what, they were sexually active their whole life. It might be just a continuation. So the other thing that the family would be helpful in is telling us what are the patient's values and preferences, right? What if we can't, based on what you know with your mom or dad, are they a fighter? Do they hate pain? Have they had a good quality of life and they're done now? Would they want to live at all costs? Right? So you can have those conversations. And I know, like my ex-wife, she would want everything done and she want to live at all costs, probably because she wants to keep spending my money. But I know what her values would be. You know what I mean? That she would want this, even if I don't know the specific thing she's here for. I could say, you know what, my wife is really a vitalist. She would want to, for us to be as aggressive as we can for as long as we can. So this is kind of the way we go. The third thing, if we don't have this and we don't have this, we go to the best interest standards. And the best interest standard is determined by looking at two things. One is the prognosis for the patient. And the second is the invasiveness of the proposed procedure. So I should discuss them in the opposite. So the invasiveness of the procedure is, as you know, how invasive is the procedure that we're proposing, and what's the patient going to get out of it? Are we going to make things better or worse? So it's not a sentiment where the mom says, I always have my son's best interest at heart, or I always have my kid's best interest at heart. Of course, but we're talking about a very specific thing. So an example would be, we had a patient who had 9 suicide attempts in a 2-year period. And the most recent suicide attempt, she jumped out a window and broke her neck. So she was going to be quadriplegic for sure. And she was being transferred from one of the smaller centers to the regional here. And we thought her heart might stop in the ambulance on the way. So then there was no one there to make decisions for her, no one we could consult about what her wishes were or her values and preferences. So we had to make a decision about her best interest. So if we do CPR on a person with a broken neck, it is a particularly invasive procedure, very much so, right? Mm-hmm. What's it going to do for the prognosis? Well, if she survives this, it's going to make things a lot worse. So in that circumstance, we would have reason to think that resuscitation would not be in her best interest. Do you see what I mean? So we're not judging her as a quadriplegic or suicide attempt or any of those things. We're just saying the invasiveness of what we're proposing to do. And the opposite works as well. If it's a moderately invasive procedure but a fantastic prognosis, then you would say treatment's in the patient's best interests. So the best example is the Jehovah's Witness, right? As a Jehovah's Witness, I might be able to refuse blood products for myself, but can I refuse for my child? who's say 3 or 4. And what every court in the country would say as well, a blood transfusion might be moderately invasive for a 3 or 4-year-old child, but what's the prognosis? And we can say natural life expectancy. They would say then treatment is clearly in the patient's best interest according to this. So it might not be in their spiritual interest, it might not be in the parent's best interest, but it would be in the child's according to this. So these are the responsibilities of the substitute decision maker and the family. And this is what, like I said, what their responsibilities are as opposed to what their rights are. So now if we go to a situation where the family disagree, we can look and say, okay, what do they disagree about? Are they disagreeing about what the patient's wishes were? So I had a situation where the wife told her husband, I want to be a full code and I want them to do everything they can to save me. And then she told her daughter, her daughters, I've had a great life and I'm ready to go. I don't want to be a full code. So the patient herself gave family members contradictory information. So now the father's saying to his daughters, no, your mom wants to be a full code. And the daughters are saying, no, Dad, she doesn't. So they have a disagreement about the patient's previously expressed wishes. Fortunately, in that case, I could go talk to the patient myself, and she was still competent. So it wasn't, if she was incompetent, we would have had a problem there. But since I could talk to her, she just said, look, I don't want my husband to think that I left him voluntarily. So she said, I've had a good life, I've had a great marriage, and I'm ready to go, but I don't want to leave him with this. So I said, that's no problem. Right? We can make sure he doesn't get the impression I'd be leaving him voluntarily, and we can work on that. So if the family are disagreeing over a patient's previously expressed wishes, that's a very good thing for us to try to work on. Or what would he want or she want, or what's in their best interest. But typically, what we have is, we have the child that gets off the plane from Toronto and says, I want everything done. I'm not ready to go. I have unresolved issues with my mom or dad. I'm not ready to let them go. So we had this case recently where a lady, she was a lawyer working for Health Canada in Ottawa, gets off the plane and she comes to see her dad. So I had just read the neurology report that said that the neurologist who was doing the assessment on her dad said, there's no sapience here. The guy's body is just responding reflexively to stimuli. So she said, the example she gave was that he was holding her hand and she had to actually pry it open and she said, this is purely reflexive. When the daughter's sitting there and we're about to do the family consult, he's holding her hand and she said, see, he's so scared that he doesn't want me to go. There's no way you're going to convince her that that's not what the truth is, right? So, but in that case, it was very difficult, but it was necessary to say to the daughter, our responsibility to your dad is to do what he would want us to do or what's in his best interest. Not what do you want. Not what you want us to do, not your unresolved issues, not your baggage. And I wouldn't say it to her that way, but you see what I mean. So this is really what I would say the responsibilities of the families are. So if they're fighting amongst themselves about what they want, you have the son who says, I want this for my mom and I'm going to do this. And then another child who says, well, no, I don't think that's the best way to go. They're arguing about what they want. And our job would be to say, no, the discussion should be, well, what do we have any wishes that apply clearly and unambiguously? And with advanced directives, that's nice, we can, but very frequently we don't. This one is very subjective a little bit. So if families are disagreeing about this one, we would probably have to go to this step. And like I said, that's where we would be looking at the invasiveness of the procedure and the prognosis for the patient. Any thoughts or comments or questions?
So going back to your first example with the gentleman that deteriorated but didn't want to tell his family anything. So it would just pretty much stop at the previously expressed issues. Because
Exactly.
that's what he didn't want.
Exactly. He was pretty clear he didn't want his family to do it. So we would go to the best interest standard and say, okay, we're only going to provide treatments to him that are in his best interest. And those would be ones that, regardless of how invasive they are, they improve the prognosis.
Mm-hmm.
That's what we would do. That's not what they did, but that's what, the result of this analysis would be. And this is kind of like an analytic framework where you can use it to figure out from our perspective. We don't need to share all this with families, but we can use it in our perspective to say, okay, if you guys are disagreeing about what we each want, how about you go back and meet and say, what do you think your mom or dad would want? Not what do you want for her or what do you want for her, but what are your reasons for thinking this is what they want? And then you can say, and the other thing we're looking at is what's in your mom's best interest. And I know you all love her or him or whatever it's going to be, but we're looking at, resuscitating your mom or dad or what their code status is going to be, and they're never going to get out of the ICU. But to do this, we might have to break bones and all this stuff. So, we can kind of change it, the conversation from people with rights disagreeing to people with responsibilities trying to figure out what's best. Any thoughts, comments?
I just have a question. So if as a patient, I have a substitute decision maker and it's someone that I have chosen because I feel they'll act in my best interest. And then, so say, in my case, it would be my husband, but my dad and my brother come in when I'm in the ICU and they decide that they don't think that what my husband is doing is what is the right thing.
Yeah.
Do my dad and my brother have rights over my husband who I've chosen?
No, this is a great example, because what you've done is you've empowered your husband to make this decision.
Yeah.
Saying, you're saying, I can't be specific enough to anticipate every fact situation that's going to happen, but you're my husband. We've had intimate conversations over a long period of time. So if anyone's going to know what my values and preferences are in a situation, it would be you. Right? So it'd be very, work with your husband a little bit to make sure he's not just being self-serving.
Yeah.
But if he's genuinely saying, this is, like I said with my ex-wife, I know that she'd want everything done. She's told me this over many, many, many years.
Yeah.
Right? So if her family came in and said, no, I think we should stop, I'd say, well, that's not what she would want. You see what I mean?
Yeah.
So your husband, so you would be empowering him on this level of the hierarchy, which is very good to do, right? That's exactly what we would want, because how do we know what you would want? But it's a great example.
So as her ex-husband, are you giving your thoughts or opinion about what she would want?
Well, I
You know what I
don't
mean?
think she's gonna make me her power of attorney.
But where you've had the conversations with her and that sort of thing, and you know what she would want, and the family can and say, would you give your opinion to the family and say this is?
If they ask me,
if they ask.
for sure.
Yeah.
But if I was to appoint a power of attorney, I might very well appoint her, because even though we don't really like each other, we know each other. So she would be in a really good position to do these things. Because we had a case one time, and this is kind of comical, of a lady who was living in the community, and she was in her 80s, and her activity every day was to go to the superstore and get some groceries. So she'd take a taxi to superstore. But when she called the taxi, she'd say, that guy hasn't shaved. I think he's going to kidnap me. I'm not getting in that car. Or that car is too filthy. I'm a woman, or a lady. I can't be seen in a filthy car like that. So she would send 2 or 3 or 4 taxis back every day. But what happened was she really fell in love with the dispatcher's voice. So she said to this taxi dispatcher, I want you to be my power of attorney. So she wrote up all the letters with her lawyer and said to him, I don't want us to ruin what we have by seeing each other and meeting each other, but I want you to go to my lawyer's office and sign the documents to be my power of attorney. So he did. And then she ends up in the hospital, not able to make decisions for herself. And you want to see 4 pissed off daughters. Right? This guy comes walking in with this legal document that she was mentally competent when she signed it, and she has the right to appoint whoever she wants. And the daughters are livid. So when I met with them, I said to the guy, I said, well, do you have any idea what her previously expressed wishes were, or values or preferences as a person? And he said, no, not really. I said, so you're not a particularly helpful substitute decision maker, right? So you're legally authorized, but you're kind of useless. So I said, the daughters here have a really important role to play, even though you're the one legally authorized. So I said, my recommendation is we do this as a team. But I said, I hope you can appreciate it. If you don't know what she would want or what kind of person she is, you're not able to do, exercise, even though you have the legal document.
Well, in a scenario like that, would the test for competence be the ability to understand consequence, or?
Well, she was living in the community at the time, and her lawyers thought she was competent enough to appoint a power of attorney. Yeah. But the daughters are pissed off.
Yeah.
And I actually talked to her, because just because someone's incompetent doesn't mean you can't talk to them and stuff. And she said, oh, I hate those brats. Yeah. True story. So that's really all I prepared. I know we only have a half hour for
Yeah.
your mornings.
No, that was great. Does anyone at home have any comments? Feel free to unmute yourselves. Say hello. No, that sounds great.
All right, guys, well, thank you. Have a great
Yeah,
rest of your
thank you
day.
for
Thanks
being
the
with us,
invitation.
Dr.
Yeah.
Christie.
And I love your Wisdom Wednesday stuff, because like 30 minutes is just perfect to get everyone together and keep things rolling, so it's wonderful.
All right, thank you.
You're welcome.
Sorry, they were mine.